Welcome to Fridays with Feldman. Today, in preparation for Dwarfism Awareness Month, I've invited my partner, Dr. Arun Hariharan, to talk about skeletal dysplasia, which is the same as dwarfism, or one of the causes of dwarfism, and to discuss the spine in patients with skeletal dysplasias. And I think that in preparation for October, which is coming up, and awareness of these people with these conditions, I thought both Arun and I would discuss this with you. So we're going to start with just saying the one big thing is that different conditions have different problems. Not every patient who has a skeletal dysplasia or a dwarfing syndrome has the same spinal issues. They are completely different, but they're also very predictable. So I'll get started with one, which is going to be achondroplasia, which is the most common form of skeletal dysplasia. Then Dr. Hariharan or Arun is going to discuss some other types of skeletal dysplasias as well. So the first one, this is if you can see here how someone can just have a plain scoliosis, someone can be missing a vertebrae, and this just shows you that the spinal canal, which is this little black mark in here, is being compressed, and that's called spinal stenosis. So this is a slide that I really like to show what does it mean to have spinal stenosis, and I've showed this before at Fridays with Feldman. It means that your spinal cord doesn't fit through the tunnel of your back, and that's what happened here. This Amazon truck is trying to drive through a tunnel that does not fit it, and that is exactly the same thing that happens in achondroplasia to the spine. The spinal bony elements are too small for the spinal nerves, and that causes this compression, and eventually the nerves just get all bungled up like one big large accident. So we ask a lot of questions of our patients with achondroplasia. We say, every time we're about to operate on them, we say, are you getting weak? Are you having problems going to the bathroom? Is your time limiting walking? Do you have to squat down when you walk? Could you walk 3 blocks last year or walk through a department store now or a mall, and now you cannot walk any further? And any of these are all signs that something's going on, that there's some problem going on in your spine that may be causing these changes. And these other symptoms: low back pain, leg pain. Do you have numbness, tingling, heaviness, can't go to the bathroom, you're having trouble going to the bathroom or can't control it? After you walk a while, your leg's getting tired, and is all that relieved by squatting? So these are some of the symptoms and the questions that we ask. And this is a pretty typical patient with achondroplasia. Basically, we see that they have a round back, that's called kyphosis. The spine is getting shorter distance in here as they get down, and that's causing this spinal stenosis. And this patient came in basically paralyzed, and we were able to treat them with opening up the spinal column, placing the rods in to hold it in place, and then actually adding this bottom little device that allows us to be certain that we're going to get welding on the bottom. Why do we use the rods? Because otherwise it collapses the spine. You can't open it enough to warrant to making it possible. This 14-year-old with the same condition and really the same type of the procedure where we put it on. But basically, we have to do the rods if we're opening it that wide. Otherwise, the spine will deteriorate. This is the same 14-year-old, a different 14-year-old. There's a little device making sure it welds together on the bottom, put in through a little incision called an X-lift. And this is what happens if you don't have it. A 56-year-old had no rods, some decompressions, can barely walk, can't step on multiple medications. So that's the natural history of achondroplasia. That is the natural history. It is a tough condition. They get spinal stenosis, they have problems, but it is treatable, and it may require some treatments as the patients get older, but it is treatable. That's the most important thing. So now I'm going to hand it over. That is achondroplasia. That's one of the dwarfing syndromes, and now I'll hand it over to Dr. Hariharan to discuss some of the other ones.
Thanks, Dr. Feldman. That was very insightful. As you know, we've been studying this, and you've been doing this for a long time, and some of these steps, like the cage at the bottom that he's talking about and putting the rods in higher, are to prevent the most common complications that we've really studied through Dr. Feldman's experience over the last so many years of doing this. So the other common conditions, this is an example of a patient with what pseudoachondroplasia. It's another common one, and unlike kyphosis or stenosis, in this patient population, they get the classical form of an S-shaped scoliosis. And this can really be progressive as the child grows, so it's important to keep an eye on it. And this gets a typical spinal fusion like in idiopathic scoliosis, all from the back. And Sometimes, again, because of the bone morphology isn't totally normal in patients with different types of skeletal dysplasias, we add a little cage to the bottom to help diffusion take place there too. And this is another example of a patient with the same exact thing, pseudoachondroplasia. And if you'll notice on the x-ray here, you see a screw up in the cervical spine. It's important to keep an eye on the C-spine in patients with various types of skeletal dysplasias to make sure there's no instability, which can really be life-threatening. And this is what this young 13-year-old patient ended up with. And switching gears to another type of dwarfism is called diastrophic dysplasia, another common one that we see. And in this patient group, there can be a lot of issues with the extremities, with the joints, but spine and scoliosis is particularly common. And this is actually a 5-year-old, and you can see he has early scoliosis already, but he also has a malformation or a congenital issue that he was born with that causes the scoliosis to form. So because this was caught early, he had a limited fusion up top to stop that from worsening, and we'll keep an eye on him as he grows. And you can see he had a cervical spine fixed as well, because in dystrophic dysplasia they had the same issues with instability of the cervical spine. And there's another patient with a 14-year-old patient. As he grew, his growth plates are wide open, and the scoliosis can get really pretty severe and cause him to lean forward and become decompensated. And fixing this can have a really big impact on their quality of life overall. So lots of different types of conditions with different presentations of spinal conditions, and just important to have a full body assessment and learn what the different patterns of spinal involvement are in these different dysplasias.
Yeah, and I think it's so important that we reiterate the fact that, especially with Dwarfism Awareness Month and Skeletal Dysplasia Awareness Month, that it is not inevitable that someone who has a skeletal dysplasia or dwarfism will become disabled. It is not inevitable that you have to be on narcotics or chronic pain medications. These are not this is not inevitable. And I think that the fact that we can treat them and you can become functioning without having to be on narcotics and be pain-free, just managed. It is manageable. It's not easy. There's nothing easy about this, that's for sure. That's why I think there's an awareness month about it. But it is treatable. And one of my colleagues who runs a adult skeletal dysplasia clinic in New York City even came to me after I talked about what we do for the spine and said it's so important because she sees all these adults who have so many problems and are on chronic pain medications that have never been treated. I don't think that just not treating this is okay. I think that there's ways around this, ways of remaining functional, working, going to school, and I think that between ourselves, we've really, as Dr. Hariharan said, we've really tried to spend a lot of time on looking at what the outcomes are. What are the outcomes if we do this? How do we change it? How do we grow it? How do we evolve it? And we're even getting together with other centers in the country to try to create uniform treatments of these conditions. So we all welcome you to ask questions. Both on our emails will be on the bottom of the screen. You can always email us. You can call our offices. We're certainly available, but certainly email is the easiest way to reach out to us. And we'll try to answer you and try to be a more personalized treatment for what you have. And there are ways of downloading your imaging. So I don't think this, in the new brave world of technology, it really is pretty incredible that we can have put our PAC system, our computer system, all of your old imaging, and then with telehealth, it really makes it quite able to give you opinions. So have a great October, everybody, and stay well in the fall. And thanks again for joining us for Fridays with Feldman. Thanks, Arun.
Thank you.
Appreciate it.